Beautiful. All right. So thank you, everyone, and welcome to another round of the University of Toronto Corneal Learning Series with, this is the third series on kind of refractive surgery, or maybe this is a little bit kind of related to refractive surgery. We're going to be talking about keratoconus detection and management. And we have our guest speaker coming again, Dr. Kersner, who started off last week with cases, a taste of different things that we do in our refractive center at TLC. Today, we're going to be focusing more on keratoconus detection and management. There's a lot to go through, but we're trying to give an overview of all the different imaging modalities and the technologies that we have and how to put them all together. So there's a big didactic portion today, but hopefully we'll get some good interaction from the audience, and everyone who has any comments or any thoughts, please chime in at any time. And Rhonda, without further ado, you can go ahead.
All right, thank you so much. And thank you for having me again. So the first case, just to start us off with thinking about keratoconus, is this young gentleman who was actually referred in for LASIK. So he was 22 years old and his uncorrected wasn't too bad. It was 20/40 in each eye. And he had, fairly moderate astigmatism, correctable to a fair 20/20. A little bit thinner than average. The average corneal thickness is usually around 530 to 550 microns in the center. So he was a little bit below at 497 and 490. Very regular, keratometry readings. So not necessarily maps, but very not flat, not steep case, very regular case. And we talked about last week about how we figure, how much tissue we have and how much left over we'll have underneath the ablation, so the residual stromal bed, so to speak. And even though this young gentleman has a thinner than average cornea, if we subtract a flap of about 105 microns and we subtract the treatment, which is about 33 microns to get rid of that astigmatism, we're still left with a very robust 350 microns. We're happy if we see, 300 to 80, so 350 is very robust. So up to this point, I think we'd all be thinking that, he's doing well in terms of qualifying for LASIK. But then we soon discover that his corneal maps are anything but eligible for LASIK. So I'm sure we all can recognize here that he has keratoconus in both eyes. He's doing pretty well because his cones are so inferior. They're kind of, where you see that dashed line over here. So this is the Pentacam view of his corneas. Just to start at the beginning, these are elevation maps. So they're in terms of heights from an average best fit curve or a baseline, a sea level. So anything that is warmer in color than green, so the yellows, the oranges, the reds are higher than that baseline. So the computer figures out the best fit curve, and anything that is above that will be represented in positive numbers or hotter colors, warmer colors. And anything that is lower than that is represented in cooler colors, so blues and sometimes even purples. This is representing, the top left corner is representing his anterior corneal surface. This is his posterior corneal surface. This is what we're used to seeing from topography, so just a sagittal curve map. And this is his corneal thickness map. It's always nice to have a corneal thickness distribution, not just one central reading to look at. So we can see here that in all of the scans, there is this inferior steepening that is classic for keratoconus. And so, this just sort of screams out keratoconus, but there's a lot of cases. I spend the majority of my time discussing with, the team, what do you think? What do you think? Because there's a lot of cases that are not as obvious. So for example, this case is someone who has fairly regular elevation maps. I mean, in the middle, you'll see a little bit of an elevation on his front corneal curvature and a little bit more on his posterior corneal curvature. And we'll talk about that a little bit later on, why sometimes it's more on the posterior corneal curvature than, well, I shouldn't say curvature, elevation map, than on the anterior elevation map. But really what I'm looking at here is that his cornea is steeper than average. The thickness is fairly normal. So this would be one of those patients that we would look a little bit more carefully. You know, is this someone that we want to do LASIK on? Because there's detecting patients who have keratoconus and routing them for keratoconus treatment, but then there's also intaking patients who are here to be screened for refractive surgery, and you can have a subclinical keratoconus that you tip over by ablating and thinning their cornea and destabilizing their cornea. So you have to be, you know, a little bit more sensitive and have our radars on a little bit higher when we're looking at removing tissue, especially if we're removing a lot of tissue, so they have, you know, high prescription. So this cornea is steep, and, you know, we'd have to look a little bit more into these elevation maps to see if we feel that there's something suspicious further. And this does come up again later on in the presentation. This cornea is interesting because it's very regular on the anterior and posterior elevation maps. You know, green is good, green is baseline. So you're not really seeing any localized change. On the sides, we'll always see this whenever there's a little bit of toricity, because you have to imagine that the major meridians are falling away from that best fit curve if there's any kind of astigmatism. So to see the blue and the red off to the sides, especially when they're perpendicular to each other, is just toricity of the cornea. That's fine, but I'm looking for hot spots sort of more centrally. This is a very regular pattern, but it's quite thin. So, you know, we look at that a little bit more closely. This person has inferior steepening here. So we talk about that a little bit more. You know, is this inferior steepening the beginnings of keratoconus? Everything else looks fairly normal. So you can see that there's all these subtle variations that are more mild than that straight out keratoconic eye. So the best thing to do is really to get good at interpreting all of our data to see how things play out. So one of the things that we've noticed is that not all inferior steepening is due to keratoconus. Some patients have a decentered apex. So their cornea, this is the same eye that you're looking at here. The left representation of the map is the eye looking straight on, and the right representation of the map is when the eye is a little bit decentered, or the angle kappa is such that you're not getting an online view of the eye. You're having this angle. If you took an egg and you tipped it a little bit down, it wouldn't look symmetrical to you anymore. So there is another paper that talked about this. It was in Contact Lens Spectrum in 2020, and they talked about having two corneas that were normal but looked abnormal because of a decentered apex, and how they went through different suggestions of how you tease apart all the other information to try and put it in the bucket of normal but decentered apex, or suspicious keratoconic, subclinical keratoconus, form first keratoconus, at-risk keratoconus. Not like it's screaming out at you, but you know, you're trying to tease apart the two. The other thing is that you can't exclude all of the irregular corneas that we see, because there's a lot of them. There's probably at least 25% of our patients that have some degree of asymmetry across their cornea. Sometimes the corneas are scarred or injured, but they're not biomechanically compromised. And so we have to be able to offer treatment to these patients who can qualify for treatment. And we favor doing topo-guided treatments for these patients so that while we're treating them, We're also addressing their corneal irregularity and regularizing them somewhat to try and improve their best corrected vision or their quality of vision. So topo guided is even more important on an irregular cornea than it is on a regular cornea. So what do we have at our fingertips in terms of being able to fully analyze a patient in terms of degree of risk for keratoconus? We have topographies, we have tomographies, we have epithelial OCTs, which is a little bit newer to all of us, and higher order aberration maps, which are also a little bit newer to us. So I think we're all most familiar with topographies and tomographies. So we're going to start there. These are just all different units that do the same thing or similar functions. So topographies, of course, are based on placido disc images that get projected onto the cornea. And where the rings are closer together is where the corneas are steeper, and where the rings are further apart represents flatter corneas. And if the rings are more circular, then that's a spherical cornea. If they're more oval, that's a astigmatic cornea. But if they're distorted, then that's an irregular cornea. So the computer software will interpret and mathematically calculate this all out into color-coded maps, but that's all based on those rings projected on someone's tear film, and it helps us understand the contour of the anterior surface of the cornea. And what we're most familiar looking for is for irregular astigmatism when we're trying to screen for keratoconus. So that comes in two flavors. One is asymmetrical astigmatism, where the sides of the figure 8 or of the bow tie are lopsided. You have usually inferior steepening compared to superior steepening. A term that a lot of people use is an IS ratio, an inferior superior ratio, which I'd like to change to a difference, because it's not a ratio. There's no fraction there. What it is basically a subtraction of the K reading from the top to the bottom, and you're looking for a difference there of about 1.5 diopters or more in order to be a little bit of a yellow or red flag. Non-orthogonal astigmatism, of course, is when the bow tie is bent in some way.
Can we actually pause for a second, because there's been a bit of a discussion on the side about the scales, and Dr. Teichmann, you mentioned that you can chime in here. So do you want to bring in your thoughts on what you have to say about the scales? In general, we try to use the absolute for in our clinic to just be consistent across patients, but there's been a question about whether having a scale that is with smaller increments would detect milder changes, and that's by Dr. Weil, one of our fellows. Dr. Rootman or Dr. Teichmann, did you want to comment?
I can comment. Oh, go ahead.
Go ahead, Josh. Go ahead.
I was just saying, so there's actually two different issues there. There's a few. One is absolute versus relative scale, and the other is step size in the scale. So an absolute scale means, that the darkest color is whatever the machine is set to. It's the flattest cornea. The brightest color is the steepest cornea. And no matter who walks in the room, that's the same scale. So if someone has a totally normal cornea, but it's like 35, they're going to be, whatever greenish, dark bluish color. And if they're, 60, they're going to have whatever reddish color. And if they're in the middle, they're always going to be that color. It has to do with it. And so when you have a cornea that varies in K values, those K values are going to be wherever on the rainbow that patient happens to fall in on the absolute scale. Whereas a relative, and the reason we like to use that is we can memorize what colors are concerning. We know red means whatever K number it is, and we can sort of in our head say, look at the map and say, I already know how steep this person is. That's why I think most of us use an absolute scale. The other thing is relative takes the scale and it moves it so that the hottest color is always the same and the coldest color is always the same, but it fits those colors to the patient's cornea. So if a patient comes in and their cornea's flattest meridian is 75 and the steepest is 78, they're going to map that color so that there's going to be areas on the map that are blue, very blue, because they're flatter than the steepest meridian, but the Ks are super, super steep. So it actually, the relative scale is going to map the scale to the Ks. So that's not a great way to do it unless what you're really looking for is the variability in a patient's cornea, which, to be honest, most of us can see in the regular absolute maps. And if you're looking to actually see more subtleties within the cornea, that's where you reduce the step size. So going from like an absolute, a step of, say, whatever, half to a quarter, or from 1 to a half, it's going to show more colors over the same area. And that's where you're going to see more of like an inferior steepening, for instance, on a subtle cone. So the downside of that is, of course, if you make it small enough, every patient that walks in the door is going to look like they have keratoconus, because you're just looking for any subtlety is going to start to highlight. So that's sort of the two things: absolute versus relative, and then step size. And Dr. Rubin, if you want to add anything as well, by all means.
Yeah, great points, Josh. That's exactly right on. And in fact, you can take almost any cornea that has a little bit of astigmatism, and if you make the step size small enough, it'll look like keratoconus. And so you don't want to do that. You're going to get way too many false positives. The way that Steve Kleiss told me, and Steve Kleiss is, I believe, the father, the grandfather of corneal topography, is that he likes to use his scale, which is 1.5 steps, and an absolute scale, so that he says it represents more or less the refractive power of the cornea. And if you make it too small, you're going to pick up all kinds of abnormalities that really aren't there. So you get an awful lot of false positives. The other thing is that we're talking about screening now for keratoconus, or screening patients for refractive surgery. You want something that is really easy to see. And just like I love the way Rhonda said it, green is good, so you can literally look at a Pentacam and the BAD assessment and know within 2 seconds whether that patient has something that is abnormal or something that really needs to be honed in on.
Great, thank you. So just to clarify, so the absolute scale, is the step size also set? Or you can, like, it's just the color gradient that is?
You can change either of them, except on some of the maps you can't. Like if you're using the holiday scale or the holiday maps, it won't allow you to change the step size or the absolute. If I'm not mistaken, you can't change it on that one. But like if you're putting together your own 4 maps that you want to use for refractive surgery or for abnormal corneas or whatever, you can adjust those, and you can do it all on the OPD scan. Personally, I like to stick with this Smolik-Kleiss variation, because it's a 1.5 diopter step, which is enough to show you abnormal pathology, but not so much that it's going to overcall things.
Great, thank you. Dr. Kersner, back to you.
Okay, so tomography builds on topography by adding on top of the anterior curvature map other pieces of information. There's 2 very popular units in the refractive surgery world, as far as I know, the Orb Scan and the Pentacam. So the Orb Scan is built on a Placido disc tool to do the anterior curvature map. And by using a scanning slit, it captures images of the cornea and builds for us the anterior elevation, the posterior elevation, and the thickness map. And those 3 additional pieces of information are so much more informative than just the anterior surface alone, that we could not live without them. So pentacams are very similar, and we're going to get to that soon. I think there's a lot of very personal, strong opinions about which is better, orb scans and pentacams. I think that some people like the placido disc part of the orb scan. It's a little bit more, it's not as based on as many calculations to build the surfaces. But I have to say that the Pentacam has more data points, and the argument with the Scheimpflug camera is that it's based on more calculation to build the surfaces, but the calculations are a little bit more sound because the way the cornea is imaged is a little bit more sound. So we'll start with the orb scan, and we'll just take a look here. This is the anterior posterior elevation on the top, and the sagittal curve map on the lower left, and of course the thickness map on the lower right. When we're looking at this, there's a few things that we look at. So the very first thing we always look at is this sagittal curve map. I think that's what we all, go to initially. And when we see that there's any type of asymmetry, you want to know what the IS ratio is. So we use this second ring in order to calculate that. Each of these hatch marks are 1 millimeter, and each of these rings are, well, you can see according to the hash mark, this is 1.5 millimeters. So this is a 3 millimeter ring. This is a 5 millimeter ring, and this is a 7 millimeter ring. And we look to see what the difference between the 5 millimeter ring is telling us above and below center, or if you have a very tilted astigmatism, you can, kind of change your axis as long as you're staying in one straight line. So of course, this IS ratio is like 8 diopters. If you look at the top and the bottom, it's just probably 10 diopters. It's a lot. There's no question there. The second thing that we look at is, how does this elevation map look? Is there a hot spot? Is that hot spot decentered? Because normally, unless you have a decentered apex or a keratoconic eye, usually this really runs across the center of the cornea. So you can see here that we do have hot spots or higher elevations than is normal. This posterior elevation is usually around like less than 0.04, and we can see here that it's over 0.07. So we know that there is these bumps or these steep areas, cones on the front and back surface of the cornea. And they also have these irregular indices that we look at. And at the 3 millimeter zone, we get alarmed or we get alerted if there is something over 1.5 diopters. And at the 5 millimeter zone, we're looking at something over 2.5 diopters.
Dr. Kersner, can you just show them on the slide, because your cursor is not really where
Oh,
the
it's not picking
indices
up?
are? Well, it comes and goes.
Oh,
Yeah.
right over here is the 3 millimeter irregularity index, and right over here is the 5 millimeter. So this usually will be below 1.5, and this will usually be below 2.5. So Pentacam is based on Scheimpflug imaging, and it calculates the anterior elevation, posterior elevation, even the curvature map. So that's part of where the controversy lies, is it's calculating the curvature map and the thickness map. I love it. It does a beautiful job. It's just very clear to see the numbers, the patterns, and more than all of that is how much software is available in the Pentacam. So if we look over here, I wanted to get to, so this is a very even topography. I tried to pick one. Green is good, lots of green. This is a very normal topography. This was the case that we did last week, where it was someone who had a very high degree of nearsightedness and astigmatism. So it's a very thin cornea, which is so unusual, and then extra challenging because we have this high prescription. We ended up going with big IOLs for this person. But what I want to show here is how this, saddle or H is very centered. So this is just representing the toricity of the cornea, but that's what it looks like when it's a very regular astigmatism. I think that that's such a picture perfect representation of regular astigmatism. And we have our own general norms when we're looking at this. We call this the 4-map display. So, I sort of put in where we start to figure, okay, this is a little bit atypical, and okay, this is a little bit, not a candidate. So you can see here on the front elevation, we start to get concerned if you have a hot spot or an elevated bump that's, over 8. On the back surface, if it's over 11. The front curvature, of course, we're looking for those irregular patterns of asymmetrical or non-orthogonal astigmatism. And in the thickness map, we're looking at the thickness, but we're also looking at where that thinnest spot is. So it's represented by this little circle. And I like how this circle pops up in all of the maps. And you can see if that decentered if that thinnest spot is decentered, where your anterior elevation and posterior elevation, all of those things coincide, that corroborates the case, because that is very, very classical of astigmatism. That you're going to have your steep, your anterior posterior elevation coincidence with your thinnest spot, and they're all going to be a little bit decentered. So part of the software that we use and we benefit from, I think, is the Balin-Ambrosio Enhanced Ectasia Display. And it does 2 things. So this is part of the Pentacam built-in software. So what it does is it's trying to enhance our detection of ectasia by adjusting the best fit curve. So when we're establishing that sea level against which we have the elevation maps, it subtracts the 3 millimeter area around the thinnest spot. And when it does that, it'll drop down if it's a keratoconic, or if it just happens to be locally steep in that region, it'll drop the new reference curve down, accentuating that steepness or that cone above the reference line. So you can see here in this graph, so this is a normal fit with a normal cornea with best fit sphere. When we are looking at a keratoconic eye, the tip of the cone is protruding slightly from that best fit sphere. But when we adjust to the new reference shape, because we've taken away some of the steep readings, it just pops this cone out even further. But if it was a normal cornea, it doesn't make much of a difference. And so how they represent it is, your raw data is over here. So this is the elevation of the front. This is the elevation of the back, the same as this map over here. So the same in your four map display or your quad display. But then the second row is that new baseline. And you can see how the cone or the steep areas increase from 20 to 32 and from 43 to 71. So 20 to 32, 43 to 71. And this last line is the difference between this and this, the difference between this and this. If it's an abnormal cornea or a keratoconic cornea, you're going to see that these differences are quite a bit. If it's a normal cornea, it's not that different. And so what they do here is they color code the difference map, and they highlight what is atypically big for that difference. And in this eye, because it's a keratoconic eye, it's showing that the center has changed quite a bit once you reset that baseline. So it just gives us a very quick way and a very insightful way to not miss cones. not miss, codes that otherwise might be subtle and not be, viewed against the best fit sphere. Is everyone with me? Because that's a mouthful. Okay. So the other thing that it does for us is it compares the patient or cornea to a reference base that is normal and either myopic or hyperopic. You have to actually click on one of these options to have the computer pick the right data set. And it will tell us the pachymetric distribution of the cornea. Wait, let me back up. This reference database we're going to get to in the next slide. So let me start over here. So one of the things that it does is it analyzes the pachymetric distribution of the cornea. So basically what it's doing is saying, okay, we know it's a thin cornea, or maybe it isn't, whatever the thickness is. How does it compare to the periphery? Is there a big difference between the peripheral thickness and the central thickness? Because that is suggestive of keratoconus. Keratoconus is a thinning, a rapid thinning, more rapid than usual thinning towards where the cone is. And so it displays the corneal thickness changes over the cornea by these three lines being the reference level, and then the patient's thickness or their data as this red line. So these three lines really represent just normal distributions. Say if your cornea starts off at 450 microns, or maybe it starts off at 550 microns, or maybe it starts off at 600 microns. It's just giving us the, the variety of corneas that we might see, but the slope is here. And if you see a slope that is steep and is crossing more rapidly, that is not normal. That's more suggestive of keratoconus. And it displays it, it replots it in terms of percentage thickness increase. So this is just in terms of pachymetry alone, like the absolute value of the pachymetry. This is in terms of if in the center, you're, let's say 500 microns, you should be a little bit thicker still at 2 millimeters away from the center, and 4 millimeters thicker still. So you should be getting thicker and thicker. But if you're rapidly getting thicker, that's not normal. It's not so much that you're rapidly getting thicker, it's that you're rapidly getting thinner as you're going to the center. So it's just trying to highlight the delta between the periphery and the central pachymetry and how gradual or not gradual that slope is. The second thing that it does for us is it compares the patient to a reference database that is either myopic or hyperopic and normal, and it highlights a few different attributes of the cornea. So DF refers to the elevation of the front of the cornea, the anterior surface. DB refers to the elevation map of the posterior corneal surface. DP refers to the progression of the corneal thickness, so just what we were talking about a second ago. DT is just the thickness of the cornea. And DA is to do with what's called ambrosio relational thickness, which is basically a ratio of the thinnest pachymetry over the PTI. And basically, if you have a very thin cornea, that's going to increase your art max. If you have a steep curve, that's going to increase your art max. So it's just a metric in terms of highlighting thickness and thickness distribution that is characteristic of keratoconic eyes. So when it's a normal eye, all of these boxes are white. That's what represents normal. So the box color will be white. It flags, the system will do a statistical analysis and flag any of these boxes that has a standard deviation of over 1.6. And that is considered borderline. If the deviation from the average, from the mean, from what we consider, likely normal, is over 2.6, then it'll flag these boxes red. And this last D is a a weighted sum of all these other individual Ds. So it's like an overview, like a high level impression of what the cornea is. I say weighted sum because some things are more important than others to calculate this, high level impression. We look at all of the individual indices, but this overall D is what impresses us the most. So we're going to have a chance to look at a real case in a minute, but that's how it works. This was something that we looked at earlier on. This was the cornea that had a steepening over here. And it was difficult to know if this was normal. I think it looks pretty normal, to be honest. But then if we take a look at the Bailyn-Ambrosio map, we see here that there are quite a bit of flags. Sorry, I just have to get rid of the gallery view because it's over my view. So we can see here that this is following fairly well over here, but it looks like it's dipping down. Once it gets dashed, it's kind of unreliable data. But this does impress me as being a little bit surprising and worrisome or concerning, because it's telling me that when they take the front and the back surface into consideration, these elevation maps, they're both highlighted against the average finding as being highly atypical. And when they take into account all of these variables, the overall D is also highly atypical. Second eye, same thing. This is the same individual left eye. Doesn't really impress me much from this view of it, but it does make me stop and think and look at other things because of this Bailyn-Ambrosio. So when you're working in a fast-paced clinic and you're seeing all these patients, in half hour at a time, it's good to have this to kind of tap you on the shoulder, not necessarily to make or break your diagnosis. You have to look at other things, but at least as an initial way to slow down and look further. So a newer way of looking at, keratoconic risk is epithelial thickness mapping. And I'm just going to turn this over to Sarah, and she's going to go over how that helps to also corroborate our case. We're just, continuing to look at more and more things to help decide.
Thank you. All right, as you mentioned earlier, epithelial thickness measurement has come into play kind of relatively recently. The research around it started in the 90s, and Dr. Reinstein has done a lot of work on establishing the norm. There are multiple technologies on how to measure the epithelial thickness or map epithelial thickness. However, the most common and the most commonly used in practice now is the anterior segment OCT, and that is because it's non-contact and it's high resolution, fast acquisition, and can give you even wide areas up to 9 millimeters, while other technologies like the in vivo confocal microscopy or very high frequency ultrasounds and Scheimpflug have some disadvantages in terms of either their contact or their small areas. So there's limitations to that. So usually it's the Fourier domain or the spectral domain that is able to do this technology, not the time domain OCT. And the one we have in our practice now is the iView, the OptiView. And I think the FDA approved ones are usually the OptiView, and maybe, I'm not really sure, maybe the Cassia. All right, so move on to the next slide, please. In order to understand what the basis of this imaging or the mapping, we have to go back and review what the normal epithelium is and why it plays a role in our diagnosis. So the normal epithelium, as we all know, is a non-stratified columnar, stratified non-keratinized columnar epithelium. So there's basal cells, and then these cells become wing cells, and then superficial cells. And there's an equilibrium where the cells are regenerating from the limbus and then going up through like these 5 to 6 layers and then desquamating into the tear film. And this equilibrium is maintained, and there's some forces that help kind of decide on the uniformity of these cells. So if you go to the next slide, please. The normal epithelium should have around, like the established databases, around 52 to 54 microns thick. But then because of the effect of the tarsus and the upper lids, it's normal to have a thinning around the upper quadrant. So there's a difference of about 5 to 6 microns between the lower and the upper, where the thinner area would be the upper quadrant of the cornea, and then also a little bit of thinning towards the temporal side versus the nasal side. And that is minimal, but in general, if you move on to the next slide, please. They are uniform overall. So the goal is really epithelial remodeling tries to minimize any curvature irregularities, and that is debated on what the trigger is, but maybe in the literature most recently people agree on it is related to the rate of change in curvature more than the underlying stromal thickness. Move on, please. Thank you. So this is just to get us used to looking at these maps. So that's a normal, like what a normal map would look. On the left-hand side, a pachymetry map would include the stroma and the epithelium, but you can tick off if you wanted only the stroma to be on this map. And then the epithelium on the right-hand side, you can see that there is overall maybe a slight difference between the bottom and the top, but there's a uniform distribution or thickness across the cornea. And next slide. So just again just an exercise here, this is not related to keratoconus, but if you have an eye that had underwent myopic LASIK, and in this case, it's a high myopic LASIK, then the crater that we create in the middle would be compensated for by epithelium. So there will be epithelial thickening. So the eye on the left-hand side is the same eye on the after pre and post surgery, and you can appreciate that there is, as a result of the again, the change in the curvature there, the epithelium has, there's hyperplasia and it's thickened to maintain that curvature. Next, please. Where in hyperopic laser, we try and create a crater or a gutter around and to steepen the center. So that gutter will have epithelial thickening, and then over the center where the cone we created will be an area of thinning. And it can be slightly irregular, like in the top photo. More kind of just a more perfect image would be the bottom one. Next photo, please. In ectasia and how we use this is, again, it is one, you can't use it independently. It is one piece to the puzzle where you add it to the other information. So if there's an area that is steep and you see epithelial thinning, then that corroborates your KC suspicion. Next, please. And again, there's this donut pattern distribution that has been described in the literature where there is a thinning over the cone and then thickening around it. And that's what it would look like. And that thinning, I can't point, but if Rhonda you can just point where it kind of coincides across where the steepest area is. So there's the steepening there, probably the elevation. We don't have the map here, but then again, the thinning is all in the same area. Next, please. One of the nice things I found in the literature, and this is the work of Dr. Schallhorn, she's found that it's very useful and a very reliable tool in identifying the different, whether we see, like, is this KC or contact lens related warpage. If you find that there is a steepening coinciding with the thinning, then that is more likely a KC. So the area has thinned over top steep area, as in the top panel there. But then there is, if you find that the steep area is where the thickening is, like in the top bottom picture, then that's more likely indicative of contact lens warpage. Next photo, please. And again, it's in refractive surgery, this is, for example, an image of or a compilation of multiple technologies here, but you can see the back elevation is where the steep area is and where the thinning is on the epithelial map, and it's slightly decentered. This patient was deemed in the paper that was published by Wang et al., which is a review of all the published data on OCT imaging of the epithelium. They found that this patient is highly suspicious and would not be a candidate for refractive surgery because of how displaced and the thinning kind of coinciding with the steep area. And this, I just wanted to, since we have Dr. Stein here, I wanted to ask if you use this technology a lot in determining candidacy for LASIK patients, and how much do you give it weight?
We don't do epithelial mapping at this point. Approximately 10 years ago, I had one of the very first units developed by Dan Reinstein, and I did the testing myself. It took about an hour to do, and not very efficient. But today, the epithelial mapping looks far better. But I do put a lot of weight in the pentacam and posterior elevation. And that, to me, can pick up some of the very early findings of keratoconus. I just want to make one comment. Great presentation, Rhonda and Sarah. Patients in which you're making a diagnosis of keratoconus, it's really a diagnosis of exclusion. Yes, the maps are super helpful, but you need a proper slit lamp examination because there's so many different cases of false ectasia, whether it's epithelial basement membrane dystrophy or Saltzman's or corneal scars that can mimic a case of keratoconus.
That is such a great point. And to that, actually, if you don't mind advancing to the next slide, please. We're going to say this image here. So if you were going to see an area where there's epithelial thickening and some steepening, then make sure that you look at the patient, because sometimes there could be irregularity related to ABMD. And I think the photo is not showing for some reason, or is it going to pop up?
Oh, yeah, no, it does right away.
So this is a patient that had EBMD. So that's a great comment, Dr. Stein. Thank you so much.
If I could add as well, Fuchs dystrophy can also give you a keratoconus-like map if there's an area of thickening.
Just one other comment too is amiodarone keratopathy with drug deposition, especially inferior, can cause a keratoconus-like map.
Thank you. These are great points. And again, we definitely have to always examine our patients. Dr. Whitman, you meant because of like irregular thickening in certain areas?
Well, if they've got a little bit of, as a focal zone of edema, then that can cause an elevation. And if you haven't got an epithelial thickness map, or if you don't have a slit lamp, then you might miss it. And we actually diagnosed a few cases. I think one of them we were able to publish, where the cone in quotation marks disappeared after we did DMEC. And you can have the two conditions together at the same time as well. That we've also seen that, but occasionally you'll get someone who has purely Fuchs dystrophy and they don't need cross-linking, they need a DMEC.
Very interesting.
Thank you, Sarah, for the Epi OCT information. I want to go back to one of your slides here because I think it ties into a very important point that I missed talking about earlier that Dr. Stein just reminded me about. So Dr. Stein mentioned that he relies a lot, he puts a lot of weight on the posterior elevation, and we all do the same here as well, because many people have written about how the posterior cornea will show keratoconus earlier, and part of that has to do with the remodeling that the surface epithelium does over top the anterior elevation. So if you look here at this thinning over here, this is the epithelial on the anterior surface thinning, which if you looked at elevation map would compensate for the cone. And so sometimes when you look at an elevation map on the anterior, you're not as impressed as you are when you look at the posterior elevation map, because there's no masking there. So it is very important to rely more on the posterior elevation, have a higher degree of suspicion when the posterior elevation map is showing something, and not let the anterior elevation map reassure you, because oftentimes it's just the remodeling of the epithelium that is making it not as apparent. So we're going to go to our last modality. So higher order aberration maps. So this, in addition to the Epi OCT maps, is fairly new in our array of technology. Basically, what we do for topography guided treatments is we're not only programming in the patient's prescription, which are the lower order aberrations, but we're also using their topographies to guide the laser to regularize any little bit of asymmetry that they might have, or if they are keratoconic or have some kind of scar or injury, probably a lot of irregularity. And we have a way of mapping that out and incorporating that into the treatment and customizing the treatment to offset and regularize that irregularity. So if you look at these two maps here, the pentacams show the curvature is very irregular, and the ablation pattern would be deeper over here in order to flatten that steeper area. It would want to steepen above midline to try and regularize the top to the bottom, but of course we can't add tissue. So what does it do? It takes away tissue from just over that side to affect a relative steepening. So this pattern here, when we look at just the higher order aberration profiles, which we can by subtracting out the prescription from our treatments, there's a way of doing that on the unit, helps us visualize from the pattern of the treatment what kind of cornea we have. I mean, we can see it on the Pentacam, but this is just another way of viewing it. And when we look at all these higher order aberration maps, HOA maps, easier to say, we see trefoil, which are these three hotspot maps, as being quite typical, quite common, quite normal. That's the most normal common map we'll see on a higher order aberration map. Spherical aberration, we often will see after surgery. A lot of surgeries induce a little bit of spherical aberration. If higher myope, maybe more spherical aberration, but that looks like the classic sombrero that we see with spherical aberration. But what we're looking for when we're trying to screen for keratoconus or for first keratoconus or at-risk patients to develop post-op ectasia is this map, which is vertical coma. So it's nice to have that in our armamentarium to take a look to see if that corroborates a case for keratoconus as well. So I'm looking at the time. We have a few more minutes. When we see that the right and the left eye don't look alike, that's very suspicious as well. So non-mirror like HOA maps is a yellow or red flag in terms of screening for keratoconus. And to summarize, all together, we're looking at multiple maps and measurements in order to build a case. We're looking at tomographies, and we're looking to see if there's atypical steepening on the anterior and posterior elevation maps. I put posterior first because it's the more important one. Irregular astigmatism on the curvature maps, an abnormal pachymetric distribution, and the thinnest spot coincidence with the elevation displacement. So if you see, the elevation and the thinnest spot move in the same direction, that is highly suspicious. We use our Epi OCTs to look for thinning over the cone, and we're looking for atypical HOA maps. So to get back to our first case, I just wanted to show you how all of the maps look on a keratoconic eye. So we know this map here. This is the Balin-Ambrosio map, and we see that it's highlighted some of the metrics over here. The overall D is, well over 2.6. This is dipping a little bit more steeply than we would expect. Left eye, same thing. Steep slopes to the Pachymetric distribution. A lot of red flags on the Balin-Ambrosio maps. The OPD, which of course is topography, is showing classic keratoconus. We like that we could see the Myers here. That's a helpful addition as well. The orb scans are here, so it's very tear film dependent. Sometimes we don't get as wide of a map as we'd like, but we can see that the cone is definitely peeking out over here. And these elevation maps are not only very steep and atypically steep, but low. That's what you'll see with keratoconus, is like this saggy anterior elevation, posterior elevation. Like when it sags down like that, that's not a good sign. These are the Epi OCT maps. So we can see that the whole corneal thickness is thinning, not in the center, it's displaced, but most characteristically is the Epi OCT is thinning where we would see the cone. And there is a slide here that helps us correlate the two size images. So the orb scan, the second ring is the 5 millimeter ring. I don't know, my mouse always disappears here. Where's my mouse? Okay. This 5 millimeter ring is the size of the Epi OCT map. So you can't really look at the Epi OCT map and think it's all the way down at the bottom of your orb scan or your Pentacam. You kind of have to put it in the right spot. But this actually is correlating very well with where this cone is. So it's very interesting how they overlay each other. And the HOA maps, screaming vertical coma, like that's just crazy. So what would we do for this patient? Would we monitor or would we cross-link? I'm just going to go ahead. Do you want to do this poll quickly? I don't think we have time.
Okay.
Okay. We won't finish, but I'm going to just finish this case. Yeah. So we got a little bit too ambitious. Monitor for documented progression, 60%, and proceed with cross-linking now, 40%. Okay, so they're both valid. It used to be that cross-linking was only after documented progression, but we've seen a lot of movements. I'd be interested to hear what the other corneal specialists have to offer or have to say about their protocols. But we at TLC, if the patient is fairly young, like under the age of 25, we often will just proceed with cross-linking. A lot of times we'll dig into their history with their primary care optometrist to see if we can get some background. So we don't have to take today as baseline, we can take baseline moving retrospectively. But commonly they are progressing, and we do want to try and intervene before they lose best corrected vision or before they lose more best corrected vision. So it's a little bit of a race against the clock. Does anybody else want to let us know how you deal with a young keratoconic, if you monitor or if you jump in?
Ray?
Just make a comment. Generally, if they're under age 30, the chances are great that it will progress, and we do recommend cross-linking. And in fact, as you brought up, Rhonda, about the young patients, patients under 25, 12 years ago, when someone came in under age 25 and had keratoconus in one eye and the other eye was normal, we would just do the keratoconic eye. But now we're doing both eyes. We've seen so many cases of progression. And, yes, we can monitor them, but how often do you monitor them? Do you monitor them every week, every month, 6 months? And often the patients will be lost to follow up and only come in when they've lost best corrected acuity.
Yeah, great point. You know, I don't trust myself enough to follow the patients, and I don't trust the patients to be responsible. You know, a year goes by, 2 years go by. How many times have you been in the office and a patient comes in and says, gee, I thought I just saw you last year. And then you look and it was like, you know, 2014 or something. So I agree, the patients get lost, and you can really rely on historical progression as well. I mean, if you've got a certainly 16-year-old, they're going to tell you that they could see perfectly well 2 years ago and now they can't. Isn't that progression? I mean, do we really need to show it on a piece of paper to say that the patient has actually progressed? We can't turn back the clock when they come back and they're actually worse. So I agree with Ray. I think we've liberalized the indications, and you know, people were using the gold standard of an RCT, you know, where you need to have precise criteria in order to enter them into the study. Well, we're not doing that anymore. We're treating patients in the real world.
So this
Thank you.
patient,
Rhonda, I'm sorry, one more comment. We can go over a little bit. And so I'm just going to ask, Dr. Dixon has his hand raised. So Dr. Dixon, can you unmute yourself?
Thank you, Right. I think I am. The first thing is any of these charts, don't forget to check the scale. It's been referred to, but you could get one sent into you ranging, say, in quarter diopter steps, and that will alter your thinking. The second thing is Ray's mentioned the importance of a clinical exam. There are days when your equipment will fail and you actually have to rely on a clinical exam. And one of the points which Professor McCullough made during the clinical exam for keratoconus is that you look for the Fleischer ring around the base of the cone. And that is enhanced by using the cobalt blue filter, in which case the ring shows up as a black ring on the background of the keratoconus. So a clinical exam is still of importance.
Great point. Thank you so much, Dr. Dixon. Dr. Stein, you had a comment?
Just one other point that I made up rounds before is that most clinicians, when they see post-op LASIK cases and the patient comes in with 20/20 uncorrected vision at 1 year, usually pats themselves on the back and the patient's excited, the doctor's excited. It's very important to do regular pentacams or topography because you want to pick up the rare case of corneal ectasia. And frequently they can have 20/20 vision, posterior elevation, or they have inferior steepening below the pupil. That's a diagnosis of ectasia, and they need cross-linking, and that's how you preserve their vision, not when they come in with loss of best corrected.
That's great, great points. And to your point, actually, early management of eyes that have ectasia is great, but then the fellow eye, I always worry about inducing haze and or scarring from the CXL. So I personally feel sometimes kind of if they're form-proofed, I would wait, but maybe I'll be pushed more to treat them early on. Do you find that just treating them with maybe longer courses of steroids would help to prevent post-op, post-cross-linking haze and scarring?
What we've done in the last few years is we've decreased the total energy to the cornea, and that's made a tremendous difference in the incidence of haze, whether it's cross-linking alone or cross-linking combined with topography guided. So the original study used a fair amount of energy over 12, 15 years ago. And that was the initial protocol, but we found that we could get by with less energy and better, clear corneas.
Great, thank you. Dr. Slomovic?
I know the hour's getting late, so I'll be short. You know, I think the points were really well made. Rhonda, great talk, wonderful overview. And I think Bill's comment about examining the cornea as well as looking at all your, your information, your diagnostic imaging tests is great. But I think we really, the approach to the patient should be more on the basis of what they do in medicine. after the patient has the heart attack, it's too late to control his blood pressure. I think we've got to look at this as we want to prevent patients from going on and losing vision. I think, David, you alluded to that as well very clearly. So I think if we see keratoconus in a younger patient, we really need to intervene early to prevent the progression to loss of vision, because you're not going to get that vision back.
Great points. Thank you. Rhonda, we still, I'm not sure, Dr. Rootman, if we can finish. We have a few more slides. We were going to go over even the grading scale, but maybe we'll just finish up this case.
Yeah, I think we'll just finish up this case because, yeah, I think it's a mouthful to do. The other slides are more about how we handle serial monitoring. How do you compare and track for change? So you could do that manually, or you can use software like the Pentacam has to actually more systematically track that. But we can save that for another talk. I just wanted to show you this very successful case of cross-linking plus TCAT. You know, the TCAT oftentimes is just to regularize the cornea and improve their best corrected vision so that they can wear glasses or soft contact lenses more successfully, maybe not have to go into sclerals. But this guy was was mild enough and responded well to our TCAT treatment. And you can see here on this Pentacam Difference Map, which is another one of their great software tools, we can compare this post-op map. So this is from October 19, 2021. This was the pre-op map, March 10th, 2021. So a difference of, say, 7 months. And this is much smaller of a cone, flatter of a cone. And we can see when we subtract one map from the other, this is what the story is. This is what the ablation did, or what the surgeon did, is the cone is flatter. We had to flatten a little bit over here to affect some steepening over here. And that pattern helped this patient get to here and get to here. So he went from, sorry, I just have to move my gallery again. He went from 2040 unaided to 2025, and his prescription basically dropped to spiritual equivalent of 0. And the left eye, again, did phenomenally well. I don't actually normally tell patients who have keratoconus, you're not going to have a prescription, you're not going to need glasses. Usually what I'm telling them is you're still going to need corrective lenses, but you know, our goal is to have you see better in glasses and soft contact lenses, just have better quality of vision. But this one happened to do outstandingly well because he was fairly mild, which is another reason why you want to intervene early. So I think that's a good place to stop if everyone agrees.
Yes. Can we just progress to the references slide if anyone would like to capture for this talk, and the one from last week, we did not show that. Thank you so much, Rhonda. That was an amazing session. We tried to cover a lot of ground in a short time, and I think the discussion was amazing. Thank you for everyone who joined, Dr. Stein, Dr. Dixon, and everyone who's joined us today as panelists as well. That was a great input from everyone. Dr. Rootman, thank you for explaining the subtleties of the scales. I've always found that a little bit tricky, so that helps us kind of understand how to, and Dr. Teichman as well, obviously, to cross-reference again across patients. Thank you, everyone, and thanks, Robert, for joining us. Please fill out the evaluation forms for us. They help us with the upcoming sessions. We were able to look at your suggestions from last week, and that helped us make this one. Hopefully it was a good session for everyone, and we'll see everyone next week. And we have Dr. Gavoya presenting on toxic soup syndrome. Good night, everyone.
Thank you, everybody. Good night.
That was a wow session. You two are quite the dynamic duo, and we have to get you to do some more sessions. You just made things abundantly clear.
Thank
We
you.
had a good teacher.
Yes, we
Well,
do.
our teachers is each other. We teach each other. I learned from you. You learned from the residents, the other fellows. It's fantastic.
Thank you.
Really well done.
Congratulations. Great session, Rhonda and Sarah.
Thank you. Thank you so much. Good night.
Right.